Hi, thanks for joining. My name is Michelle Moser, and I am with Revelation Pharma. I'm also a former owner of Maker's Compounding Pharmacy, and you can see me at the LDNpharmacist.com. Today, we're going to talk about thyroid and LDN and how those two work together, how to compound those medications, and some of the talking points specific to those medications that will not only help enhance patient outcomes, but also will improve therapies. So let's get started. I don't have any relevant disclaimers or disclosures. We're going to talk about thyroid function a little bit. We're going to talk about the lab values that are important in fully evaluating a thyroid picture, how low-dose naltrexone helps with thyroid disease, the dosage forms of low-dose naltrexone, what are available, how easily are they compounded, and also the follow-up programs that are available that impact patient care and enhance patient successful outcomes. So let's start with thyroid. First of all, it's the wonderful little gland that sits underneath the Adam's apple. It's responsible for every metabolic process in the body. There's a thyroid receptor on every cell in the body. It helps control temperature, metabolism of nutrients, muscle, and also enhances brain function. Thyroid disorders are very common in women, much more so than in men. In fact, it usually tends to follow along on the female side of the family tree. So if a grandmother has it, usually we'll see that in the mom and then pass down to the daughter. Now, the mom can also transfer that to her son, but the son isn't necessarily going to transfer it down to his children. So if you can imagine a house, and if you leave a house without heat and there's drafty windows, eventually the paint's going to peel, the floors are going to buckle, that sort of thing. And that's really what happens when we have low functioning thyroid that's left to be untreated over time, is that our personal paint starts to peel and we just don't feel our best. There is a lot of issues associated with low functioning thyroid and hyper or high functioning thyroid. Low functioning thyroid is hypothyroidism. High functioning thyroid is hyperthyroidism. It's not uncommon, especially with individuals who have autoimmune disease, that they actually fluctuate between the two. There isn't necessarily purely an autoimmune disease where there's only one or the other. They tend to kind of bounce back and forth. That's where the symptomology can be kind of troublesome to kind of navigate. And it's also really confusing for the patient because, how is it that sometimes they can have a lot of weight gain, bloating, puffiness, and then other times they're they feel like they're climbing the walls and they're have rapid heartbeat and they're just not very happy at all. There's a laundry list of symptoms that are associated with both. Now, thyroid function can also be an autoimmune disease related issue, and those antibodies not only affect the thyroid gland itself, but it can easily affect other organs in the body. So it is very important to identify those thyroid antibodies and what's going on, and also the role that low-dose naltrexone can play in treating those antibodies. And I definitely want to thank Isabella Wentz for this wonderful, wonderful graphic. So let's take a functional medicine approach to hypothyroidism. So usually we're taking a look at TSH, free T4, free T3. We also want to take a look at those antibodies, whether they're TPO or thyroglobulin. If you can also take a look at reverse T3. Reverse T3 is how cortisol is taking the active thyroid element of T3, taking that molecule and literally flipping it. So it becomes an isomer of its actual active component. Because it is a rotated isomer, it's no longer active. But we see a wide variety of medications that play an enormous role in thyroid function, specifically oral estrogen use. If there's a lot of estrogen dominance, that can severely impact thyroid function. It can actually suppress that quite a bit. Synthetic hormone tends to have a greater impact than natural hormone. Chronically if we are not sleeping well, if we've got a wide variety of insomnia, or if we just can't shut things off at night, that can also impact thyroid function. If we are using higher than normal levothyroxine or naturally desiccated thyroid, we can also see issues playing with the symptoms, and that's where it can become really confusing on how to sort that out. There also tends to be an enzymatic deficiency in quite a few people where they poorly convert levothyroxine to liothyronine, so the inactive thyroid molecule to the active thyroid molecule. That enzymatic process where it literally plucks an iodine off, so that's where you go from T4 to T3, it becomes active. That enzymatic process is calcium driven, so we can also see later in life the issuance of an osteopenia or osteoporosis diagnosis. Other oral medications, whether we're treating for blood pressure, diabetes, a wide variety of other issues, can also play an impact with thyroid. There can also be nutritional deficiencies, specifically in chromium, selenium, vitamin D, zinc. We also have to take a look at that iron panel, because iron, especially the ferritin level, will have a great impact on thyroid function as well. And we can't forget zinc. Zinc actually plays a large role here. And then just overall lifestyle is, what exactly are they eating? Are they moving? Do they drink enough water? All of those things. Often patients are shown and told, you know, your thyroid functions are fine. Your labs came back completely normal. Well, what exactly does that mean? Because just because the lab tests come back in the normal range doesn't mean that the symptoms just magically disappear. In fact, a lot of times they don't at all. Lab tests are generally done with just TSH alone. And quite honestly, the lab values and the standardization for TSH was developed back in 1934, so almost 100 years ago. And it was never really meant to be the absolute gold standard. It was used as a tool to also navigate the other areas of thyroid function, specifically what is going on with T4, what's going on with T3, and evaluating those antibodies. Of course, if the antibodies are completely negative, there's no reason to look at those every single time, but perhaps once every couple of years or every 5 years would be important, because someone can develop thyroid antibodies later in life. Now, TSH is a thyroid stimulating hormone. That is a hormone that's released from the pituitary gland to then stimulate the thyroid to get going and start making some hormone. But what if the medications that we're using can actually change that rebound mechanism? And what if those antibodies actually play a larger role than what we have usually seen? And we can see that even more with today's research and development on the testing of thyroid. Most issues are missed, and literally years, if not decades, go by, and the symptom list tends to grow and grow, and the health tends to decline further into other comorbidities. So once upon a time, you know, people thought, oh my gosh, what is this lump going on in my throat? And they were often treated with antidepressants. Sometimes the thyroid was removed because of goiter or because of nodules, or it could be irradiated as well. But sometimes they are told that they have, well, if you're going to have a cancer, this is the good cancer to have. And quite honestly, in my professional opinion, I don't think any cancer is great to have, but we really need to further take a look at what exactly is going on. And that's where further testing becomes very helpful, because then we can further evaluate the entire picture, not just the corners of a puzzle. So here are two pictures. These are pictures taken from way back in January of 1915. This is the exact same woman, Dr. Eugene Hertog, who was I believe, a great-grandfather of Thierry Hertog, who currently practices. Did quite a bit of thyroid evaluation and symptomology and treatment in Europe back in the day. This was gleaned from Dr. Mark Starr's book, Hypothyroidism Type 2, The Epidemic. And this is literally the same woman before treatment and then 4 months after treatment. So let's take a look at what has actually changed. So when you take a look at her cheeks, on the left, they're quite puffy. She's got a large bag under her eyes and over her eyes. Her hair is long, but it seems to be rather dull. It also doesn't seem to be very plentiful. She also has a very thick neck, a large chin. Her nose seems to be rather bulbous, and her lips are rather full and puffy, which, I mean, a lot of people are looking for that anyway. But when you take a look at the picture on the right, her hair is shining in the picture. It seems to be much more luxurious, have more luster. You can actually see hair growth around her temple and above her ears. You can see the puffiness in her cheeks have declined. So you can actually see the contour there of her upper mandible. She no longer has the big puffiness on her nose, around her eyes, in her cheeks, and under her chin. And her clothes tend to seem to be fitting much better. It doesn't look like it's the same dress, but you can definitely tell where the picture on the left, it almost looks like her dress is choking her. And again, this is another woman back from January of 2015. Picture on the left is untreated. Picture on the right is treated, again, just 4 months later. Now, back in 1915, all we had available was naturally desiccated thyroid derived from porcine values. And now it is standardized, and now we call it armor thyroid and P thyroid. We also call it natural desiccated thyroid or thyroid USP. So it is still used today, but you can see the lady on the left, again, has a lot of edema in her face and her neck and around her eyes. The part in her hair is quite wide. She also looks rather lethargic, and you can see the swelling in her hands and also in her abdomen. Whereas on the picture on the right, she has lost a lot of that edema. There's actually more shine in her hair. She looks as if she can move her joints much better. She looks as if she's lost some weight. She actually looks a lot less puffy. She has definition in her chin. She only has one chin, and you can actually see her cheekbones, which is lovely. It's also very curious. Even today, you could walk down the street or be in an area where there's a lot of people, and we still see a lot of people that look like these women on the left, even today, 100 some years later. So here's a gentleman who was treated again, and pictures are 4 months apart. So this doesn't affect just women, but it does affect men as well. And here you can see that his hair is grown in. The picture on the right is just 4 months later. His glasses fit much better. He's down to one chin. He's got a lot less puffiness in his face. He has definition around his ears, and it looks like his clothing fits so much better as well. So a little therapy really can go a very long way. So what exactly what we should be testing? So a lot of times we're confined as practitioners as to what to order, primarily because there's insurance guidelines that will or will not pay for things. But ultimately, it really is up to the patient as to whether or not they are willing to pay for things. Even if it's not covered by the insurance, perhaps the patient will pay out of pocket. And there are some fairly inexpensive out of the pocket processes to do some testing. So if you don't test, you don't know. If we're only looking at thyroid stimulating hormone, it is only that hormone that's measured, leaving the pituitary to then interact with the thyroid gland. If we look at total and free levothyroxine or T4, that is the inactive form of thyroid. So it really doesn't tell us whether or not that individual is converting to the active hormone. So T3, which is liothyronine, we look at a total and a free amount. That is an active valuation of thyroid hormone. It is made not only at the thyroid gland, but it is converted at the cellular wall by an enzymatic process of pulling one iodine off of the T4 molecule to make it then active and then interact with the mitochondria. If someone is really stressed and they have a lot of cortisol can actually interact with that same receptor site that the T3 will bind to. And as it becomes T3, cortisol can actually flip it around and become a mirror isomer, and it becomes a reverse T3 and it's no longer active. And that can be evaluated in a blood test or serum test as well, or blood spot, whichever you're looking at. Thyroid peroxidase is one of the antibodies that can be produced to evaluate whether or not an individual has autoimmune thyroid issues. Usually thyroid peroxidase is associated with low functioning thyroid, whereas thyroglobulin, TG or TGB, is an antibody that causes more autoimmune function, tends to allow people to be hyper functioning. And usually if somebody is positive for TGB or thyroglobulin antibodies, we do not want to use desiccated thyroid USP, even if it is natural, even if it contains not only T4, T3, but some T2 and T1. But the biggest difference is that porcine-derived natural thyroid is 4 amino acid chains different than what a human is going to make. So it's not uncommon that if they already have antibodies being produced, they can actually make more antibody against the medication that you're trying to use to help with their thyroid function. But we also need to take a look at some of the other disease states, because we're not just a thyroid. It is part of the endocrine system. The endocrine system also compiles and is a comprehensive overview of the other hormones specifically associated with the sex steroid hormones, some of the neurotransmitters, what's going on with insulin and pancreatic insufficiency, if there's any there. But also what is happening in the gut. Is there a dysbiosis or an imbalance that is causing a wide variety of pathogens to grow, or the bad guys to grow, so that maybe somebody has a small intestinal bowel overgrowth? Perhaps it's a fungal overgrowth. What if it is H. pylori or other kinds of irritable bowel issues that could lead to reflux that can also then look like some symptoms associated with low functioning thyroid, but really is associated with the gut? And of course, we have to pay attention to the gut as well, because as we take oral medications and they go to the gut to be absorbed, if that's not functioning well, if that's leaky or we're just not absorbing very well, then perhaps the inactive ingredients in the tablet or capsule could actually decrease the absorption of that active ingredient even further. Sometimes colorants will do that. It's not uncommon if somebody has autoimmune issues. They may have a gluten intolerance, lactose intolerance, and those can be associated with further decline in patient symptoms as well. Thyroid's not functioning well, we see a higher incidence of cardiovascular disease and also weight gain, which are some of the major issues that we see patients on a regular basis for, that patients definitely want to correct and feel better later in life. Diet is absolutely a 4-letter word. No matter how you spell it, diet is a 4-letter word, and it comprises of everything that we eat and drink. Gluten is absolutely bad news when we're dealing with thyroid disease, especially autoimmune thyroid disease. So gluten looks like a thyroid molecule. It can very easily substitute on the cellular wall and then allow for functional hypothyroidism just because there's gluten available. Nutrition is very important, not only at the beginning of the day, but throughout the day, as is hydration. It will absolutely make a difference as to what is absorbed, what is then metabolized for end products that are then reabsorbed, transferred to the brain to either make us happy or sad, or produce those medium chain fatty acids that work as brain food, which then allow us to collect our thoughts and be thoughtful rather than forgetful. We also need to be careful of medications that we're using. There's a wide variety of medications that can actually lead to low functioning thyroid. Amiodarone, for example, is very often associated with low functioning thyroid. So if somebody has cardiovascular issues and amiodarone is on the medication list, very important to take a look at a full thyroid panel. And sometimes it is the difference between hormonal balance and the ability to lose weight. Often insurance is a huge barrier as to getting a hold of good lab results. And again, that is something that perhaps the patient can make a decision on as to whether or not they have the means for out-of-pocket expenses. And then follow the symptoms, document what's happening. Is something happening differently during the winter months or during the summer months? Is there something associated with different diets? I mean, we tend to eat different things in the summer than we do in the winter. Perhaps even what we're drinking is different in the summer or the winter. Our vitamin status can be very different as well. So supplements are really important to take a look at. And of course, your movement, if you are more mobile during the summer, that can definitely have an impact on your thyroid. So here are some treatment options when we're dealing with low functioning thyroid. We can treat with levothyroxine. There's a wide variety of commercially available brands and generics out there. They almost all contain lactose, which is shown on the package insert to reduce the dose and the absorption of that dose by about 50%. It also assumes that if you're just giving levothyroxine or T4, that's assuming that that patient's going to actually convert to T3. Most people do not. So there can be completely normal TSH and T4 blood levels, but yet symptoms continue, and symptoms can continue to pile up and may become more difficult to unravel. So liothyronine or T3 is the only active form of the hormone that helps with thyroid function. Again, there's commercial brands and generics available in very limited supply of strengths. So usually a 5, a 25, or a 50 microgram. Most people need someplace in between. Also not uncommon that somebody needs a little bit of T3 twice a day, morning and early afternoon. So levothyroxine has a half-life of anywhere from a few days up to maybe even 7 to 10 days, depending on if they're hyper or normal or low functioning thyroid. Liothyronine can have a half-life of a few hours to a day or two. So that can also be an issue when we're trying to treat as well. Now, desiccated thyroid USP commercial brands are Armor, Nature Thyroid, Thyroid Strong. NP Thyroid is a generic for Armor. Nature Thyroid, WP Thyroid, West Thyroid, not as available. So that lab is no longer making those products. 1 grain of desiccated thyroid is equivalent to 38 micrograms of T4 and 9 micrograms of T3. So 1 grain, whether you're using the French conversion or the metric conversion, is either 60 or 65 milligrams. And so of that tablet, you will see the standardization of 38 micrograms of T4 and 9 micrograms of T3. So the beauty of that is that if for whatever reason someone is not doing well on desiccated thyroid, perhaps it's shown that they have positive thyroglobulin antibodies, TPO antibodies, so they need to be using a levothyroxine and liothyronine combination, then we can literally use this as a guide to then do further calculations and then hone in on that individual's dose. And the commercially available products usually contain sugars, whether it's sucrose or dextrose, usually starches and lactose as well. So again, can further decrease the absorption of that product. Now, when we're compounding, really important to get to know your compounder. Not all compounding pharmacies are the same. Not all of us have the same formulas. Sometimes we use gelatin capsules, sometimes vegetarian capsules. The diluents to fill up that capsule sometimes can vary compounding pharmacy to compounding pharmacy. So there are no standardized formulas. They also need to make sure that they are, if they are making levothyroxine and liothyronine, that their triturates are being evaluated by an outside third-party lab to ensure their potency is exactly what they stated as such, so that when they further compound those capsules for your patients, we want to make sure that they're as accurate as possible. And then you also want to look at more labs to evaluate thyroid function, anywhere from 4 to 6 weeks, starting therapy of new dosing. Always, doses can be tailored to fit the individual's needs. We do not have to conform to those 6 strengths that are commercially available. We don't have to do that. We can find something right in between, and we can change it as often as every 45 days if we need to. It's very easy to do. So when we are looking at blood spot testing, that is an at-home kit. There's several labs that offer that. You can, with a panel of looking at TSH, free T3, free T4, TPO, the antibody, runs about $175 to the patient. And you can be combined with looking at the sex steroid hormones and also cortisol levels as well. And so the price usually goes up to around $380 or $400, something like that. We always got to take a look at supplements, and there's a wide variety of combination products to help support the thyroid function, but we want to take a look at individual needs as well. Not everybody needs a huge combination. Usually we need to look at selenium, chromium. Be careful of some states where your soil levels of selenium and chromium might be higher than in other states. So my understanding is that, for example, I believe Michigan is a high selenium state, whereas Washington is not. Even though we're on pretty much the same latitude, it can be different. Always look at a complete iron panel as well, what's going on with ferritin. Sometimes just by normalizing iron panels, you can normalize thyroid function. It plays a very important role. And of course, there's other adaptogenic herbs as well as those amino acids that are used to convert T4 to T3. Tyrosine, for example, is in that enzymatic process. Micronutrient testing is available as well. There's several labs that do that. And that's a way also to further evaluate that complete patient picture. I always suggest that the patient buy the best brands that they can afford. We always look at their budget and make sure that we're recommending the best brands that are out there, not necessarily in a large bucket either, primarily because every time they open that container, there's going to be humidity and air getting in there and circulating around. And so by the time you get halfway through that really large bucket, things are going to change, right? And we can see that in that the color of the capsule gets darker, or it gets plumper, or even breaks, or it smells funny, things like that. And that's usually going on because it's in a very humid area. A lot of people keep their supplements and their medications either in the bathroom or in the kitchen window. So again, light is a variable, heat, humidity, all of those can be quite impactful on not only supplements, but medications as well. So when we're dealing with low dose naltrexone, so this is a compounded medication, it is prescription. It is commercially available in a 50 milligram, 100 milligram tablet. It's been around since 1964. It's one of the most, in my 35 years of being a pharmacist, I've never seen another molecule studied as much. So here we are in 2023, and quite honestly, there's 925, 950 articles written on low dose naltrexone used in various disease states. So that always raised a red flag for me. It's like, how can one medication be applicable in so many different disease states? Well, the bottom line is the mechanism of action of how low dose naltrexone works. So if you're going to Google it, Google low dose naltrexone. If you just Google the word naltrexone, you're going to go into alcohol overuse syndrome, how it's used in methadone withdrawal, all of those things. But we're talking about low doses. We're talking about anywhere from 1 microgram up to approximately 6 to 9 milligrams. And we'll go through the dosing and all of that as well. But the mechanism of action of low dose naltrexone is very different than traditional dosing of naltrexone as well. What we see with low dose naltrexone is it helps to normalize pathways to decrease inflammation, modulate the immune system, and it will also intermittently block those same pain receptors that we use for opiates. So we can use this for chronic inflammation, acute inflammation. We can also use it for chronic pain, acute pain. It's not like taking an analgesic. You're not going to see relief in 20 minutes. It does take time to kind of trick the body to function more efficiently along its natural pathways. It does work at the cellular level, so that will benefit almost all diseases because almost all diseases are based in inflammation. So when we look specifically at the toll-like receptors that LDN interacts with, and also the cytokines that produce inflammatory responses or also tend to suppress the immune system, and LDN actually reverses that, then that's how this medication works incredibly well in a variety of areas. When we're dealing with thyroid, it actually helps to reduce those antibodies. It can also be helpful in thyroid eye disease. So it's usually compounded in capsules, in liquid suspensions, in transdermal gels, nasal sprays, topicals, which is different than transdermals, sublingual troches, and even sterile eye drops. The patient will need some follow-up as doses need to change every 7 to 14 days. So we usually start low and gradually increase over a period of time until we find that individual's happy dose or unique stopping point. There are currently 3 books that compile the majority of the research that's been done on low-dose naltrexone. Very easy to remember, the LDN book, volume 1, volume 2, and now volume 3 was just released this last November. They are all edited by Linda Elsegood, who is the founder of the LDN Research Trust, and each book has different chapters, so they're not an extension of one another. The only chapter that repeats is the very first one, which goes over the mechanism of action. Every other chapter is unique to each one of these books. And it continues as you go into book volume 2 and book 3, you will literally see a deeper dive into very specific disease states. So how does LDN work? Well, this is a very, very, very short list. Because most diseases are based in inflammation, in my professional opinion, if there's an inflammatory process, I think LDN should be given a shot. It is low dose, low side effect, low drug interaction, and low expense. So to me, it's kind of like, why not? But we use low-dose naltrexone specifically for pain and inflammation, whether we're dealing with a chronic low back pain, inflammation associated with fibromyalgia, with chronic fatigue, even looking at some of the acute injury issues. Those are all very easy to use low-dose naltrexone with. A wide variety of autoimmune diseases like multiple sclerosis, Hashimoto, or Graves' disease, which are 2 different types of thyroid disease, fibromyalgia, Lyme disease, Epstein-Barr virus, Crohn's and ulcerative colitis, even situations that are even more intense than that. Depression. Low-dose naltrexone isn't necessarily a monotherapy. It works really well and plays well with other medications. We use it in autism for children and adults. We can use it in diabetics, specifically type 2, but also type 1. We're seeing it used even more so in Parkinson's disease, as well as in dementia and Alzheimer's. And of course, it helps with cancer. There have been papers, scientific papers and case studies done on beta cell lymphomas, on pancreatic cancer, as well as on breast cancer. And those are just a few to note, but also digestive disorder cancers. We use it quite often for eczema, psoriasis, and rosacea. We always use an oral medication, but we can also use a topical, and topical is used to help specifically with those symptoms associated with the skin disease like itching and redness, not necessarily to treat the underlying issue. That's where we would use the oral medication, but you can use oral and topical together. Very common. Low-dose naltrexone can be prescribed by anybody who has the authority to write a prescription. You do not have to be specially certified. You don't have to go through any special training, nothing like that. Most prescribers are not aware of low-dose naltrexone because it's not commercially available in low doses. There are a few clinical trials in in process, one specifically on digestive disorders for Crohn's and ulcerative colitis, and there's another one for chronic regional pain syndrome as well. But what's different about those processes is that when those clinical trials are being performed, those doses have to be very specific. So they're not necessarily going to be individualized. And what we've learned over the last 20 years or so of compounding low-dose naltrexone is that about 50% of the population will respond to kind of a traditional dosing regimen. But we can capture probably another 30 to 40% by individualizing their doses and really honing in on what their happy dose is. What we find with low-dose naltrexone is that less is more. We slowly increase the dose over time. There are literally binders of information, a wide variety of electronic documents as to what it's being used for. Dartmouth University, one of the physicians at Dartmouth, took the first 900 articles that were written up until his point of compilation back in 2018. Anyway, he combined those and developed a wide variety of charting so that if you were interested in all the articles that were written on multiple sclerosis, he would have a table for you of all of those articles, the processes of those studies, the doses used, the outcomes, and the methodology for those studies. There's also a lot of case studies that have been published as well. And when you read the LDN books, you will find that each one of those articles and case studies are noted in each one of those chapters. If you need any of this supporting documentation, please let me know. I'm more than happy to supply that for you. So what can providers expect, but also what can patients expect? The bottom line is that LDN doesn't cure anything, but it simply causes the body to work more efficiently and effectively to modulate the immune system, to block those pain receptors intermittently, and to reduce pro-inflammatory cytokines. We start with very small doses and we slowly increase over time, usually starting at once a day. Some individuals with chronic pain, sometimes we start with twice a day dosing, and we're using a small dose in one end of the day and a different dose at the other end of the day. Usually once a day dosing is used at bedtime, but it can be used in the morning. We do see, in my professional opinion, I think we see better results if it's dosed at bedtime. We do see about an 18-hour increase of endorphin production over a period of time when used at bedtime. And we see that endorphin production when it's dosed in the morning. I just don't think it lasts like 18 hours. I think it's a little bit shorter than that. So anytime you can produce additional endorphins, there's an improvement of the immune system, but also to help with pain and inflammation. Some people get quick relief. Others don't find relief until around month 4 to 6. And that is very clearly documented in a wide variety of disease states. And it's mainly because when we have a patient in front of us, we can't really tell by looking at that person how inflamed they are. I mean, yes, there are going to be some physical attributes that we'll be able to evaluate, but clearly what is really happening metabolically in their body. So there needs to be individualized dosing so that we can see individualized response. So then the other question that we hear quite honestly and quite literally every single day is, will I have to take LDN all my life, or can I simply stop it when things improve? Well, the answer to that is we have had people on low-dose naltrexone for decades, and they've done very well on that. Anybody can stop low-dose naltrexone at any time. There are no side effects to that. You don't have to slowly decrease the dose or anything like that. You just simply stop. However, the symptom list that was present before you started low-dose naltrexone will probably come back after stopping low-dose naltrexone. Because again, LDN doesn't stop anything. It doesn't cure anything. Sorry, it doesn't cure anything. It does stop a lot of processes. You remove that molecule and they come right back. We can very easily make a variety of dosage forms. So here in this picture on the left are some of the capsules that are made. Sublingual troches are in the small picture in the middle. And then we always find that if we are able to provide the patient with a colorful chart to help them follow along, and we try to make it as easy as possible, then we have better outcomes. So for example, if someone is going to start on low-dose naltrexone, it's a 0.5 milligram capsule, and they're going to increase by 0.5 milligrams every 7 days, we often prescribe, or dispense that in 2 containers, a blue container that contains the 0.5 milligram and an amber or yellow container that contains the 1.5 milligram. And then as you see on this chart, if they read left to right, following the week in the gray column, they will read left to right. Do they take anything out of the blue bottle or anything out of the yellow bottle? And we do that because when you're dosing medication at bedtime, if they end up taking a big pile or a big handful of capsules, they got to wash it down with a lot of water, and then they're up all night going to the bathroom. So we try to make it as simple as possible. Now, we also can make liquids, and we make liquids in, I'm going to go back real quick here. We make liquids, and we also make charts associated with that as well. So a lot of times with liquids, we're going to be helping individuals who are incredibly sensitive to medications. We hear that all the time, right? That this individual is incredibly sensitive to medication. So we can start with very low doses, perhaps 0.1 milligram, and slowly increase that dose. Now, if somebody is also taking opiates, so that is the primary issue of contraindication of using low-dose naltrexone, because it will bind that same opiate receptor, knocking the opiate out, and therefore they will end up in pain, or if they've been on opiates for a while, they may end up in withdrawal. However, there was a study done, I believe it was with Yale, with a potential commercially available product, never really made it to market, but it was literally a combination of microgram dosing of naltrexone along with a little bit of oxycodone. So as they slowly decreased the oxycodone dose, they increased the microgram dosing of naltrexone, and they were literally able to substitute one for the other, getting them off of their opiates. They could literally kick their opiate habit. And then we moved out of microgram dosing into 0.1, 2, 3 milligram dosing, up to low dose, up to maybe 3 to 4.5 milligrams. Now, naltrexone is also commonly used for weight loss. So we can make capsules for that as well. That's a commercially available product called Contrave. It contains naltrexone 8 milligrams and bupropion, I believe 75 milligrams, maybe it's 50 milligrams. But what we have found is that a lot of people react to the low dose naltrexone and they don't feel very good when they first start it. So we will usually start them on low dose naltrexone 2 to 4 milligram, and then help them work up with that with a second prescription of bupropion. And then we have better successful outcomes. And this medication, naltrexone at any dose, can tend to suppress appetite. So that can be very helpful for those individuals that are trying to lose a couple of pounds. But really, my message to everyone is that no individual is ever alone. As a practitioner, we are here to help support you. We're here to help provide you with scientific data and patient case studies so that you can feel comfortable prescribing not only compounded medications, but medications in general. We need to address the factors that are looking and suppressing or changing the function of the thyroid gland, perhaps even the autoimmune issues, any of those antibodies that can be taken care of with low-dose naltrexone. Also addressing issues associated with cortisol being elevated or significantly suppressed, as well as the sex steroid hormones. We got to fix the gut. And if we start thyroid therapy, we need to be patient and evaluate again in 4 to 6 weeks, especially if we are on thyroid medication and low-dose naltrexone. It's not uncommon that we see antibodies decrease using low-dose naltrexone, or simply disappear. And then the thyroid tends to normalize its function. And in doing that, we don't want patients to be over medicated. So we want to take a look at thyroid panel, the complete thyroid panel, about every 4 to 6 weeks until the dose of LDN is stabilized and until the dose of levothyroxine, liothyronine, or thyroid desiccated is stabilized. You can always reach me. I'm happy to help. This is my personal cell number. You're welcome to text me, call me. You can reach me at the LDN Pharmacist. I'm on social media. And this is my personal email as well, mmoser@revcustomrx.com. Thanks very much for joining me. I hope you have found some helpful information. And as always, be well.